Afternoon, everybody, and thank you, Linda, for that kind introduction. And I'm going to speak to all of you without slides for about 25 minutes, 25 minutes about where we are with the pandemic, how the pandemic has affected the healthcare system, what the impact is likely to be on policy, and how I believe that the pandemic is really going to accelerate many of the changes that were already starting to happen before the pandemic hit. And I will finish a little bit by talking about future pandemic preparedness. All of this, I think, will help shape what I hope in the second half of the hour will be a discussion about policy, the impact of these policies on rehabilitation, rehabilitative care. So I'm going to not talk about rehabilitation per se. I'm going to cover it a bit more broadly, and then I hope that in the Q&A we can get into the details. So let me start by talking about the state of the pandemic and where we are. So here we are, late April, and the state of the pandemic in many ways depends a lot on where you are. And in the United States, the good news is that I think we're on the tail end of the kind of acute emergency phase of this pandemic. What do I mean the tail end? I mean the fact that by the time we get into the summer, life will really begin to return towards a new normal. And that new normal will be a pretty good normal. Will be in many ways very similar to what we had before the pandemic. There will be differences, and we'll continue to manage this virus. The virus will not be gone, and we will have to deal with it on an ongoing basis. But the ways in which it has totally shaped our lives is going to begin to ease, I think, by the summer, if not even before then. And so let me talk a little bit about that, and then I'll talk a little bit about the global scene, and then I will, as I said, shift to talking about the healthcare system. So why do I say that? Well, as of this morning, about 52% of adults in the United States have at least one shot of the vaccine. And it's really the vaccines that are our ticket out of this pandemic. In some states like Maine, Connecticut, Massachusetts, Rhode Island, that number is over 60%. And what we are seeing across the country is infections now really starting to decline. And among older people, we are above 80% of all people over 65 have gotten at least one shot. About 66% are fully vaccinated. That other 14% will get there in the next few weeks. And that's remarkable because it means among older people, this pandemic is largely coming to an end. So right now, when we see 60, 70,000 cases a day, it's almost all in young people. It's almost all in unvaccinated people. And we really have two situations in America, the vaccinated half where infections are plummeting and the unvaccinated half where infections are still quite high and quite substantial. Over the next month, 6 weeks, my hope is we can take that 52% of adults vaccinated and get that number up to 65, 70%, at which point things will get dramatically better. We still have to work on children and getting kids vaccinated. 16 and 17-year-olds can get that now. I think younger kids will be able to get vaccinated, 12 to 15 probably by June. And there will be young kids who will not be vaccinated probably for many, many months. But the pandemic really will begin to take on a very different shape and a much, much better one. So I expect a really good summer, good start to the fall. I expect later in the fall into winter, we might see a bump up in cases. It's a pretty seasonal virus. But overall, the acute phase of this pandemic will be behind us, and we will really start thinking about what does life look like afterwards. That's the good news about the United States, and it is really good news. Globally, things are far more challenging. India is in the throes of the worst days of the pandemic. It had registered 335,000 cases yesterday, over 2,000 deaths. Those are huge underestimates of what's actually happening. The healthcare system of India is collapsing right now. And I don't use that word lightly. Things are very bad. Things are quite bad in Brazil. Much of Europe remains in difficult shape. So it's a funny and complex moment where you have some countries like Israel, UK, India, UK, Israel, America starting to pull out of the pandemic, but many, many countries very much in the throes of it, and the world's still in the throes of it. And the world is not going to pull out of this pandemic until we get the world vaccinated And that probably represents the single biggest public policy, public health, economic challenge that humanity has faced, which is how do we vaccinate 7 billion people in relatively short order with the vaccines we have. And there's a lot of work being done. And I'm happy to get into a discussion about all of that to the extent that that is useful. But I want to shift now to talking about how this pandemic has affected the healthcare system, because of course the impact on the healthcare system has been quite profound. What we have seen in this pandemic is, while there have been, in the United States, 570,000 deaths from this pandemic attributed directly to the pandemic. The truth is that we think a lot more people than that have died as a result of the pandemic. And the a lot more people really falls into two buckets. Some more people from COVID who were not diagnosed, but a lot of people who died because of the impact of the healthcare system. People who chose or weren't able to go to the emergency department when they got sick, people who had disruptions in their primary care, people who really died because the healthcare system was under such substantial stress. And there are different estimates out there of how many of the excess deaths that represents. Anywhere between 1/3 and 2/3 of excess deaths, maybe from non-COVID related conditions, but really because the healthcare system was so incredibly stressed. We saw this last spring and summer, in March, April, May, where elective procedures got shut off, a lot of in-person physician visits. Obviously, so many of the things that many of you are engaged in on rehabilitative care also became remote. These are fundamentally hard things to do remotely. Some of it easier than others. So we saw this huge increase in telemedicine, which was quite good. And we think that some of those changes are absolutely likely to stay. But other things like the delays in surgery were a real problem. Obviously, you can't do that remotely. And I will be curious how the more kind of the rehabilitative aspects of healthcare, how that has gone. Because on one hand, I can imagine that there's a lot you can capture and do remotely, but there's obviously some things that are harder. And so it was really quite a significant mix of effects. Let me say a couple more things about the effects of this pandemic on the healthcare system. So there are a couple of things that strike me as particularly problematic. One is we saw, beyond just people canceling elective surgeries, we saw and have seen huge drops in vaccination rates, huge drops in preventive services, colon cancer screening, breast cancer screening, diabetes management, all the things that we do to keep people healthy and well. We've seen huge decreases in all of those over the last year. And there is more and more evidence that there were real hits to cancer care, cardiovascular care, delays in chemotherapy. And I think it'll take years for us to sort out all of the negative effects, all of the spill-on effects. So often people think about, well, elective surgery, if you delay it by 2 months, what's the big deal? I think, first of all, we all know it is a big deal. Elective surgeries are rarely discretionary. They need to be done. They just don't need to be done emergently. And the impact on care goes well beyond elective surgery into all sorts of other fundamental services that we provide as healthcare providers that not just help people live longer lives, but better lives and functionally better lives. So I think it's going to be a long time before we sort out all of the costs of all of that. Let me say maybe two more things about this, which I think will then get into thinking about policy issues and the policy implications. So in the middle of the biggest health crisis of a century, one of the most odd things that we noticed was that healthcare systems were getting financially really beaten up. You had more and more hospital systems that basically came on the brink of filing for bankruptcy. You had ambulatory care provider organizations and I'm thinking about physician offices, others who basically became financially bankrupt, could not sustain the models. And so you have this health crisis, and yet the economics of the healthcare system just don't work in that health crisis. And that, I think, has been a huge wake-up call for policymakers who are now starting to think about, where does this all need to go and how do we change things? So in that light, And actually, before I talk about the policy implications, let me maybe just make a few more points of things that I think the ways in which this pandemic has impacted um, uh, the healthcare system. And then I'm going to finish talking about where all of it needs to go, especially as we think about the future and future pandemics. So beyond the financial impact, of course, on the clinical side, there have been very large effects on physician, nurse, other providers, uh, on their mental health. We've seen really substantial increases in burnout. Over the last few weeks, we're seeing more and more stories emerge of providers, healthcare providers who basically say, we got through the year, I'm quitting. We saw that with a lot of nurses in the fall and winter. As the second surge came, a lot of nurses who had been on the front lines basically deciding they didn't want to go through another surge. So I think the providers that are the backbone of the healthcare system are going to come out of this pandemic quite battered and bruised, and maybe fewer of them. And we're going to have to really think about how do we shore that up. There have been a few successes of the healthcare system, actually many successes of the healthcare system in the pandemic. I already talked about the shifts to telemedicine, the ability to manage as much as it was able to do. But there are a couple of other things that I think are really important to mention as huge successes of the healthcare system in the pandemic. And the one I want to highlight is the ability of the healthcare system to do improvements in the middle of a crisis. If you are somebody who was infected with COVID and was sick and hospitalized, let's say a year ago, April 23rd, 2020, compared to that same person infected, sick, hospitalized today, April 23rd, 2021, your chances of dying today are probably about half of what they would have been a year ago. That is a remarkable, remarkable fact. The fact that we have cut mortality for this disease by probably close to 50% in 1 year. So how has that happened? Some of it is we've gotten better therapies. We've got dexamethasone, which we didn't used to use. Now we have very good evidence that among critically ill patients, it helps. There are a few others, remdesivir maybe on the margin. But the biggest gains have come from sheer quality improvement. We have learned, who do you really need to put on a ventilator, who do you not? How do you manage non-invasive ventilation in people who are significantly, seriously hypoxic? Just overall, our ability to learn and grow in the middle of a crisis, I think, is remarkable, and it will end up having very, very large effects. I want to finish off talking about the payment model, and then, as I said, talk a little bit about the future. So the main lesson, one of the main lessons of the financial kind of bath that healthcare provider organizations have taken is that fee-for-service just does not work in the middle of a crisis. Now, there has been a 20-year transition away from fee-for-service towards what I will say in broad terms are alternative payment models. ACOs, capitation, bundled payments, you can go through all of those. But there has been a long-term shift towards those payment models. And this pandemic highlighted that we need to accelerate that dramatically. And I think probably the single biggest thing coming out of this pandemic for the healthcare system is going to be a large shift in payment models and payment approaches away from fee-for-service towards these, towards more holistic, more population-based payments. That will have effects for all healthcare providers. I think it'll have very profound effects in the rehabilitation space, where payments, especially as you start getting more bundling, you'll see potentially more provider organization consolidation. I think it will have lots of interesting impacts, and we can talk through all of that. All right, let me make a few more points, and then I will wrap up and get into questions and discussion. So one of the things that I have often said, and I think it is true, is we are entering now an age of pandemics. And let me lay out why I say that. And then I want to talk a little bit about what implications that has for the healthcare system, the public health system, and how they can function together. So it sounds really scary, age of pandemics. Like, what does he mean by that? And like, is life going to be like this all the time? But first of all, we need to make sure life is not like this all the time. But let's talk about why pandemics occur, why many of us for really the last 5 years have been saying we are in for a global pandemic. The quick side story on this, about 6 years ago in 2015, I put together a course, an open online course, one of these what are called MOOCs, massive open online courses, through the Harvard X platform. And it was called Lessons from Ebola, Preventing the Next Pandemic. And it was exactly as it sounds. We talked about the Ebola outbreak, what went wrong, and then said, how do we use the lessons from Ebola and the global response to make sure that the world is better prepared? And in that course, I was the main instructor, and I had lots of guest speakers that I had conversations with. And the question I asked everybody at the end, the last question I would finish every discussion with was, I would say, and this is in 2015, I would say, imagine it's the year 2020, and imagine there is a global pandemic, a virus, maybe from China. And I'll explain, I was not some genius. I didn't have inside knowledge that this was going to happen. I said, imagine it's 2020, a virus potentially originating in China causes a global pandemic. Is the world going to be ready? And every expert I talked to gave the same answer, which was no, the world is not going to be ready. So why did I set up that question that way? And this course is, by the way, available online. Anybody can take it. So why did I set up the question that way? It was because it was really clear at that point that we were kind of in an era where the risk of a global pandemic was very high. It's also really clear at this moment that all the factors that made this pandemic happen, none of them have gone away. And the risk of future pandemics is very high. We are not going to wait another 100 years to see another global pandemic. We're going to see them much, much sooner. Over the last 30 years, there's been this massive acceleration in novel infections in humans. Novel infections, meaning infections of humans from a virus or a disease where we've not known to be infected before. Why is that happening? About 90% of novel infections are zoonotic in origin. They come from animals. There has been a massive bump in increases in zoonotic infections in humans in the last 30 years. It's being driven by deforestation, economic growth, climate change. Those things are creating more and more human-animal interactions, including novel interactions, and that is leading to species jumps and new infections among humans. Combine that with globalization and the fact that the world has become so hyper-globalized, and now you understand why we're set up for pandemics, why we were set up for this pandemic, and why we're set up for future pandemics. On the globalization front, I look at 2003 SARS outbreak of China, and then the 2019 outbreak, of course, of this virus. China was, in 2019, had about 6 to 10 times as much domestic and global travel as it did in 2003. And that means that when this virus started circulating, probably in October of 2019 in Wuhan, by November, it had probably spread through much of China. And by December, it had gotten out into much of the world. And that's the reality we're living in. The reason I had set up the question back in 2015 of maybe China is because China's where all this economic growth has happened, where there's so much environmental change happening. But it isn't just China. The next virus could come from India. It could come from sub-Saharan Africa. It could come from Latin America. It could come from Kansas. It could really come from anywhere. And so what that means, and policymakers at the highest levels of US government are fully aware of this. And I bring it up because it will have effects on the healthcare system, and that's what I want to finish with. So in the past, and the way we've done things in the United States, is we think about the healthcare system, and then we think about the public health system. And the public health system is the surveillance and the public health workforce. It's not very well funded. It's got really bad IT systems, and it's sort of the poor cousin. And then the healthcare system, the $3.5 trillion healthcare system, is where all the resources go. The doctors, the hospitals, the facilities, the radiology, the lab, you all know all of it. There's going to be a reshifting of that. There is going to be a recognition, there is a recognition among policymakers, Republicans and Democrats on the Hill, in the White House. Obviously in the White House it's just Democrats, among governors, Republicans and Democrats, that this huge imbalance where most of the money goes to the healthcare system, very little to public health, just cannot stand. So there's going to be some interesting policy issues that come out of this. And there's going to be much more interested in thinking about population health. There's going to be much more interested in trying to bring public health and healthcare systems together, more integration of IT, more investments that bring these entities together. And there will be a really interesting set of questions of what is the role of the healthcare system in public health. And that, to me, is an interesting opportunities for new payment models, new ways of really thinking about driving health and not just healthcare. And given the broader shift towards alternative payment models, I think that's going to feel really comfortable for a lot of policymakers. So a lot of changes ahead. If you think the last few years have been moving fast, I would say buckle up. Because my sense is that the pace of policy over the next 5 years is going to make the pace of policy in the 5 years before the pandemic look slow and clunky. We're going to get a lot of changes in how healthcare systems are organized, who gets to do what, lots of conversations about issues of scope of practice. All of those are going to come much more into open, lots of new conversations about payment models, delivery models, IT systems, the role of public health. It's going to be an exciting 5 years. And when I think about what many of you focus on, most of you focus on around rehabilitation and rehabilitative services, thinking about people's functional status, thinking about what are the things we want to be measuring and holding people accountable for, you're going to have a pretty central role to play in all of this. So lots to come. And let me actually stop talking and see if we can get Linda back, and maybe we can have a discussion and I can answer. I've seen a lot of questions coming in through chat. And so maybe we can get to whichever one of those you want, Linda, but let me take a pause
Super.
there and turn to Q&A.
Thank you so much for those remarks. And we'll begin with a question from Christine McDonough. Just building on the point that you've just made, can you comment on the potential role of rehabilitation providers in the likely shift to support more public health? Like how can rehabilitation providers and researchers be more involved in that?
Yeah, it's a really good question. There's going to be a rethinking of what is the role of public health and what is public health and what are the boundaries between public health and healthcare. And in that context, I think you're going to see public health agencies be much more pushed towards being held accountable, and healthcare systems too, for measures of health that go well beyond, did you get your hemoglobin A1C checked, and did you get your aspirin for your heart attack, but much more into things like how are people functioning in the community, and when I start thinking about the world in that light, which is where I think a lot of the metrics are going to go, how well are people doing, what's their quality of life like, there I start thinking about the incredibly important role of rehabilitative services. We have this mental model, you may not, but most policymakers have this mental model of rehabilitation as like something terrible happens, you get in the hospital, and then you get discharged from the hospital, and you need some sort of rehabilitative services, or you are injured. But I think we're going to see a lot more proactive. How do you improve people's functional status? How do you engage in these kinds of services to boost up people's ability to get out and do things, even if it's not preceded by some untoward health effect? Now, I feel like saying this to all of you is going to sound really obvious, but in my mind, in the policy world, rehabilitation still is largely seen as a reactive thing that comes from responding to a crisis that's happened. And my hope is that the shift is going to be much more towards being much more proactive, working with public health agencies. Public health agencies may be thinking about a large group of seniors and how do you keep them functional and healthy and mobile and out of the hospital and out of doctor's offices, and being much more proactive on these kinds of things is going to be a really important part of that effort.
Great, that makes a lot of sense. You spoke about the impact of COVID-19 on the workforce in terms of mental health. And I wanted you to comment on the impact on the workforce and the potential interest in new trainees, like in the areas of public health and medicine. And also, like, are we seeing a decreased interest in other clinical careers and an increase in public health? How is that working?
Yeah, we don't know a lot of it yet. I will tell you that Two things that I can say. One is schools of public health in general have seen about a 25% bump in applications in year over year from last year to this. It's a pretty sizable increase. At the Brown School of Public Health, and this has been really quite stunning, we've seen about 110% increase in applications.
That's the jaw effect.
What's that?
I said that's the jaw effect.
I don't know if it's the jaw effect, but it is a, you know, there's a lot of great stuff happening at the Brown School of Public Health, and I think there's a lot of excitement about it. And but it's a broader trend of this huge explosion in interest in public health. Personally, obviously, I'm biased, but I think it's awesome. My sense is you're going to see big bumps in increase in interest from medical schools. I just haven't seen the statistics and data. So I think like general interest in medicine and public health is going to go up. But absolutely, Linda, to your kind of underlying question, we may see shifts within it of what kinds of fields people are choosing, what kinds of ways they're thinking about engaging with public health or medicine. Those are likely to shift. You know, I'll make one kind of point that may feel a little bit unrelated, but I think in some ways it is, in many ways it is, which is, you know, one of the questions I get asked a lot is, when do we go back to normal? And I always say, in the short answer, the simple answer is never, because pandemics change societies. We will never go back to life as it looked in 2019, but that need not be a bad thing. We don't have to imagine that 2019 was our most glorious year and we always want to go back to 2019. We can imagine a new 2021, 22 that's much better. And so to your point of like, how does this shift? I don't know, but I can imagine shifts in where people spend their time in medicine, where they spend their time in public health. And that's not necessarily a bad thing that it'll look different than the way it did in 2019. I think it's a good thing. And we'll come out of the pandemic with a lot more people engaged in these topics.
And I think there is a real concern that there will be shortages of providers, of nurses, CNAs, and maybe rehab providers working in skilled nursing facilities and long-term care facilities. Like, what type of things can we do to incentivize and promote workforce development and make sure we have an adequate workforce in those areas?
Absolutely. And first of all, I'm worried about this. And I've talked to folks in Congress about this. And the other part that I'm super worried about is a shortage of mental health providers, because the mental health effects of this pandemic are not to be underestimated. And they're going to be quite large. So what can we do? Well, the problem of healthcare providers is they're not like widgets. You really can't like deploy the Defense Production Act and say, we're just going to produce another 50,000 doctors and 50,000 nurses this year. Like, you can try as much as you want. There is a built-in time period it's going to take. So I think there's going to be a lot of investments out of the federal government on making sure that we're building up the workforce. But it's going to take a while. And I do think we're going to see a lot of people leaving. The people coming in will take years to fill in. And we're going to have a period of time where things are going to feel a little imbalanced. It's actually an opportunity. It's an opportunity. And again, this is why I was so thrilled that you guys are doing this. It's an opportunity to rethink technology and the role of technology in all of this. Technology is a classic human extender and allows people to do things very, very differently. I think we're gonna have to rethink people's roles. One of the things that we figured out in this pandemic was when things got crunched, all of a sudden, we realized there were, nurses could do many things quite well that we used to think only physicians can do. And we found out that other people can do things that we thought only nurses can do. And so that very kind of strict box we had of who can do what, we had to break it a bit to get through a crisis. And that stuff always has long-term effects. So even, in any part from ICU care to rehabilitative care to primary care, I think there's going to be a lot of rethinking of who can do what and how do we extend people? How do we help them, to use a cliche, practice at the top of their license? And the fact that we don't have enough of these providers actually is an opportunity to learn new ways of doing things.
Here's a question from Thiru Anaswamy. In your vision, what would the ideal future look like that would combine improved higher public health focus and the prehabilitation focus that the world is likely to need?
I'd love to hear what Thiru means by prehabilitation focus.
it's be my interpretation that that would mean the rather than reactive rehabilitation in response to trauma or injury, but more improving functional status prior to.
So yeah, great. So what we were talking about before, a little bit about how I envision the set of skills that all of you bring to health becoming more incorporated into public health. And, you know, there's a lot of complexity of how we do this. So if you are a public health agency and part of your job is to think about improvement in the health and well-being of a population, let's say the people of Rhode Island, and you're the public health agency, you're the Department of Health of Rhode Island. Taking a very proactive approach, sure, it means making sure people are getting screening, people are getting their blood pressures checked, but it probably does mean for a group of people, the term, and I love it, I haven't heard it, but it makes total sense now that I've seen it, getting a lot of prehabilitation, because that's how you keep people healthy, functional, away from having bad events. Most public health agencies right now don't have a mechanism to think about how you engage. Who's going to pay for it? How's it going to work? Right? Because again, we have a very specific mental model of how this stuff works. I think there's going to be a lot of interest. There is a lot of interest in that, some of those things beginning to change. Obviously, you need to make some policy changes. You need to make changes on who can engage with rehabilitative or prehabilitative services. I love the idea of public health agency. I love the idea of the Department of Health director in Rhode Island. Is this absolutely fabulous leader, Dr. Nicole Alexander Scott. I love the idea of Nicole saying, we really need some prehabilitative care in this community, and being able to engage with a group of providers who can do that. We're going to need to figure out who's going to pay for it. How's that going to work? So there's a lot of work to be done here, but I'm here for that work. I think there's a lot of interest and excitement, and let's make sure that those kinds of things are possible and doable.
Well, this is a very related question from Samanis Koja. Thank you for the talk. Thank you for mentioning that rehab should not be reactive. This is very true. In fact, as rehab specialists, we have a huge role in primary, secondary prevention of injuries and maintenance of function. In your experience, what are some strategies in place or that you think are helpful to move the needle away from fee-for-service and towards more innovative payment models you suggested? You've just spoken about incorporating rehab providers in public health agencies, but I think this question about payment models.
Yeah, the interesting thing about payment models is, I'll say two things about them. One is, as I suggested, really probably going back to 2002, 2003. So under the first term of the Bush administration, the first Bush administration, leadership at CMS, I think, started coming to realize that fee-for-service was not the optimal way of doing healthcare payments. But we have a large, complicated health system and healthcare system in the United States, and movement has been slow. But we've been plugging away, all right? And we've been plugging away. And a lot of the alternative payment models are sort of like bundling fee-for-service at a higher level. So if you think about like bundled payments for surgery, people say, well, it's an alternative payment model, but it's a kind of a fee-for-service on some level, where there's a bundled payment for surgical services, and the rehabilitative stuff is folded in. And on one hand, that's good. It's got some advantages, it's got some disadvantages, but it still is triggered by a surgical intervention. So it doesn't allow for some of the other kinds of innovative things that are in public health or other things that we're talking about. And it wouldn't allow for a community health worker or a community health nurse or even a primary care provider necessarily to be able to trigger some of these services in a prehabilitative way. Once you get into broader things like accountable care organizations, and if you start getting the metrics right, so one of the places I have been pushing CMS for years now is on measuring functional status in populations and putting that as a set of quality metrics for ACOs. Saying you want to measure the impact of population health? Yeah, death rates are really important, but more important, for instance, than readmissions, in my mind, is functional status. And we know how to measure functional status. No, our measures are not perfect. No, like there's some challenges around risk adjustment, but we know how to do it reasonably well as a community. Let's put that into the metrics on ACOs, which is a great alternative payment model. By the way, ACOs is one of those few things that has massive bipartisan support. The Trump administration did a lot on furthering ACOs. They were created under the Obama administration. They're going to continue under the Biden administration. So that's going to become, for instance, one of the major dominant models, I think, over time. Like, let's put functional stuff in there. Let's make it much more proactive. I do think that's coming. I don't think we need to do a lot to accelerate it. What I worry about more is making sure that the payment models have the right set of metrics and incentives so we get what we actually care about, which is health, functional status, functional health of people, well-being.
Well, here's a question from Cecilia Wu, which I think speaks to a different dimension of this issue. She says, as healthcare moves towards value-based and bundled reimbursements, clinicians are still evaluated and salaried based on the fee-for-service model. And this seems to contribute to clinician burnout, even pre-pandemic, as they are evaluated based on productivity in addition to being pushed to meet VB metrics. What are your thoughts on the disconnect between healthcare reimbursement and clinician payment models? And do you think clinician payment similarly needs to be redesigned, and if so, how?
Yeah, this is complicated. On one hand, I'm really not a fan of pay for performance payments for physicians. And I'm not a fan for two reasons, both conceptually and empirically. So the empirical part is easy to answer, which is all the empirical evidence says that pay for performance for physicians, value-based payments for physicians, as you say, they don't do anything. They don't do anything useful. If you pay doctors more to order more tests, mammograms, which we may think is a good thing, they'll do that, but on the margin. But if you pay them more, but in general, physicians, like other humans, are complex humans, and saying to them, we'll give you a little extra, an extra $5 for this, a little extra $10 for this. You won't be surprised if it doesn't create the right set of incentives and it doesn't really change fundamentally how care is delivered. So I'm more game for pay for performance, value-based payments for institutions and for programs, but for individual physicians, I think it's really problematic. Now, the issue is majority of physicians have still some productivity metrics as part of their compensation. And this is tricky because on one hand, I've practiced my entire time in the VA. My payment, my physician salary, my part-time salary is really straightforward. There's no productivity metrics. I'm not doing any billing. I just get paid. And that's what lots of countries do. And so people would argue, let's just salary physicians and get away with all other metrics. I'd be fine with that. I'm totally game for that. There is some evidence that when you do that, you can see a productivity hit, that you get physicians, and I'm just speaking on physicians, other providers too, that some people, it doesn't have any effect on their productivity, but other people work less. And then we have to decide, is that okay? Can we live with that? So there are some people who've suggested a hybrid where most of the salary is fixed, but then there's a little productivity. I guess my last point on this is, over the years, I think we have figured out that there are lots of bad ways of paying doctors. We haven't quite figured out what the best way is for paying doctors.
Okay. Here's a question from Chris Barnes. Can you speak to the health inequities laid bare by COVID-19 and the need to elevate eliminating such inequities to the core value of health professions?
Absolutely. It's a great question, Chris, and thank you for asking it. And there's a bunch of stuff I didn't cover in my kind of broad overview, and this is certainly one of them that's super important. So let me tell you a little bit about what we have learned and how we make sure we don't do this again. So the pandemic has revealed what lots of people who've been studying this stuff, thinking about this stuff for years have known, which is that we have deep structural inequities driven a lot by structural racism in our country. And those inequities tend to show up, they're there all the time. They have effects all the time, but they really show up in very dramatic ways in crises, right? So when we shut down our economy, there were still essential workers. There were people working in meatpacking plants. There were people working in grocery stores. There were people traveling on mass transit. And those were the people who were much more likely to get infected in the early months. People who were doing those jobs weren't random members of our society. They were far more likely to be poor. They were far more likely to be people of color. And so we saw this disproportionate effect in terms of infections. People of color are much more likely to live in multi-generational households. We can talk a lot about longstanding housing policies, redlining, and how that shapes the kind of housing that's available. But multi-generational households meant that the 30-year-old went out to work, got infected, came home, maybe gave it to the 65-year-old who was staying at home. And all of a sudden, what was an infection in a young person that was a problem, but not maybe devastating, all of a sudden started killing people. I remember in May, there was a survey in New York of who was in the hospital. Like, it wasn't the survey of the people themselves, but it was family members being asked. And most of the people who were in the hospital were elderly. They had not been going out. I remember a lot of political leaders being really surprised, saying, I don't understand where these people are getting infected. I was like, they're getting infected inside the house because they have kids and grandkids who are essential workers who are going out and getting infected because we don't have enough protection for them. So that exacerbates all of this. And I will kind of wrap this up with a couple of key principles. Then we set up testing infrastructure in communities where we had drive-throughs, and most of those initial set of tests were all set up in suburban communities, not where the infections were happening. So if you live in one of those communities of color where infection numbers are high, it's actually hard to get a test. It was a hard to get test. Eventually this got fixed. And then what we saw was that even among people who were infected, Black and Latino Americans were far more likely to die of the disease than whites. Why? Because we have a pretty segregated healthcare system. We don't have, about 20% of hospitals in America, for instance, take care of about 80 to 90% of all Blacks, right? Healthcare for Black Americans is not evenly distributed. And those institutions tend to be poorer. They tend to be poor performing in lots of ways. And so there's all of this stuff that feeds into this. And the key is, if we are going to learn the lessons of this pandemic, it is that we have to begin to address some of those structural issues that are underlying it, that go well beyond healthcare and public health. But we also have to get our own house in order. We've got to do a better job of improving the quality and access of the organizations that disproportionately care for people of color. So there's a lot of work to do. Obviously, all this stuff has been, for some people, it's been revealed for the first time. For many others who've been thinking about this, it's not surprising. But we've got to make this one of our top priorities moving forward.
Yeah, thank you for those comments. I want to switch back to talk about telehealth and telerehab, and how might the continued use or expansion of telehealth help us to prevent or minimize the impact of future pandemics, even after COVID-19 is controlled?
Yeah, I think it's going to be a really important part of the mix. There's always, anytime you have such a significant shift as what we saw in the last year with telemedicine, telehealth, there often the responses are sort of two extremes, right? There's the kind of naysayers who are like, this only works in a pandemic and we're going to go back to the old days. And then there's the kind of super enthusiasts who are like, this changes everything, and like, who no one's going to need in-person visits anymore. And the truth, of course, we all know is somewhere in between. That for some people, in-person, face-to-face is absolutely critical. For a whole bunch of other people, it's not only not critical, it's annoying, and you don't need it, and you can do it. And so when I think about where we land right now, we're in a transition where we're trying to figure out, so how does this all shake out? But my best guess is a year or two from now, as we will go back and look at this, we will end up in a hybrid situation where we're doing a lot more remotely than we did last year, or 2 years ago. Let's say if 2019 was our comparison year, including a bunch of things that we would have never thought you could do remotely. But then there will be some things that will become even more important to do in person. And when I think about, again, telerehab, and all of you know this way better than I do, so I have a little trepidation kind of jumping into this. But I certainly think that it expands the possibilities of rehabilitative services, of for whom is it available, what kinds of things. And I can imagine that there might be, for some people, purely remote, for other people, a little bit of a hybrid. But when I think about, and again, my experience with rehabilitative services as a patient has been purely reactive. I had a couple of injuries over the years, and they were fabulous, but they were almost all in person. And now I think about, like, maybe some of it could have been done much more remotely. Like, those weren't options that we thought about before. So what happens, let me just finish off, is it's not just an efficiency gain. It expands the set of possibilities of what you can do and in whom you can do it. And I think that's pretty exciting.
So what are your thoughts then regarding payment parity for services delivered via telehealth?
I think we need to have much more payment parity. Now, we may have to think about that there are going to be potentially some different costs, but absolutely, like, the idea is, if we're really going to incentivize and allow for this industry that is emerging to thrive, we have to pay for it. We didn't even pay for a lot of it before, but we have to compensate for it in a pretty effective way so that it makes sense for people to engage in these kinds of services over the long run.
Okay, there's a question here from Alan Lee, who says, it looks as if CMS is piloting and demonstrating community partnerships to address social and various domains in low, moderate, high risks like food insecurity, transportation needs, and physical fitness for electronic health records, so that healthcare providers can pull that kind of data. Where does telehealth research fit into these various domains? Do you see interprofessional teams of telemedicine and telerehab providers to address those needs? And what are some of the barriers and new opportunities?
Yeah, I was gonna say, Alan, I think there's a lot in that question. There are 4 or 5 different facets, and let me maybe take a couple of them. So interprofessional collaboration is, I think, something that, again, it's interesting, right? If we were having this conversation 2 years ago and you had asked a version of that question, I would have given you like, we're starting to see a little bit more interprofessional collaboration, a little bit of movement. I think the pandemic substantially accelerates that in a way that becomes much more the norm. And the pandemic accelerates it because we've been forced into some of those kinds of collaborations under a crisis situation, but also with technology, it becomes very different and much more doable. By the way, it also means to me that we got to go back and look at things like training and how we train physicians and nurses. I am struck by the fact that, like, as a physician, I don't have that good a feel for what nurse training and nurse education looks like. And so part of it is, if we want to train the next generation of people to be able to engage much more effectively with other professions and work much more effectively as teams, then we got to train them a little bit together in those teams as well. So I think I've already started hearing both medical schools and nursing schools and other types of schools talk about that and talk about interprofessional training. But I think that is very much going to be part of what happens next. And as you alluded to in your question, Alan, it's a pretty fundamental part of, if we're going to start thinking about addressing, let's say, social determinants of health. When I think about who's really adept at that, no offense to the physicians in the room, and I'm a physician, I'm not sure that we're the very best people in the world. So we want to be part of that process. But if we don't do that in a very collaborative way with a whole group of other professionals, we're not going to be very successful at it. So I think, to the beginning part of your question about social determinants, absolutely essential that we have a broad group of people engaged in that process.
Yeah, a question from Maggie O'Neill. How much will health behaviors, especially physical activity and functional mobility, be on the radar of policymakers to infuse those types of new metrics that you were talking about in the creation of new public health and healthcare models? And how can rehab providers be involved in contributing to this kind of policy, especially because rehab provider roles include environmental adaptation and adaptive equipment to promote mobility and community participation?
Yeah, it's a fabulous question. So, Maggie, let me start off by saying I'm pretty optimistic that it'll be a pretty large part of how we think about things. These kinds of metrics around functional mobility, let's just say functional mobility or just function, kind of functional status. So it's obviously well beyond just mobility. I think that's going to be a large part. Why do I say that? Because I think there is very clear recognition that that has huge implications, both just in terms of how people feel and how they function in their lives, but also has huge implications for healthcare utilization down the road. The question of so how do we make sure that the right people are sitting around the table creating those metrics and executing on that? That's a fabulous question. And typically, a lot of that stuff happens through specialty societies and specialty societies putting up their hands and saying, I want to be engaged in this. I think it'll be really important for the specialty societies that represent rehabilitative providers to do that. And it's also going to be really important for those of us who are not part of that specialty, but care deeply about making that a priority to make sure we're reaching out and getting more expertise. It's one of those areas where there is a lot of expertise at hand that we just sort of tend to not pay as much attention to or have not in the past, but I'm hopeful that that'll be different. But certainly the specialty societies have to speak up and make that a priority and reach out and to the policy people and say, we're here to help and we want to make sure you do this right.
Thank you. Here's a question from Stephen Hunter. He says, you mentioned that much of the reduction in mortality with the pandemic was related to quality improvement. What do you think about the value of quality improvement research and if it will be perceived as a more important type of research post-pandemic?
Yeah, it's a great question, Stephen. And I, as someone who spent much of my life, before I got interested in pandemics about 5-6 years ago, I had spent almost all of my time thinking about quality. So as you might imagine, I have a little bias towards saying, yes, I think the value of quality improvement research will be greater post-pandemic. But I don't think I'm just saying that because I'm biased and have a predilection towards that. I really do think it will change. I really do think it will head in that direction. Because a lot of what has driven those improvements and outcomes, as I said, is quality improvement. We don't think of it as quality improvement. It hasn't been formalized in that way, but that is functionally what has happened. And so I think the more we all can make the case that it was quality improvement that bailed us out, the more people will come to realize that, yes, new therapeutics are great. Vaccines are awesome. Those are all good things. But just being able to figure out how to deliver the care that we're meant to deliver more effectively over time, learn, get better, is as powerful as many drugs, better than most of the drugs that have been developed for this pandemic or for this virus. I think we need to make the case for that. But if I plan to continue doing that, and I think if we can all do that, then I think the value of quality improvement research will only go up.
Thank you. And I have a question from Cecilia Wu. One of the things we talked about during day one was the fact that there is a great digital divide and there's a lack of broadband access across the country, and that is a barrier to access for telerehab and telehealth services in general. So she asks, even while waiting for provision of broadband access and better reimbursements, how may we use telehealth to improve health equity today?
Yeah, well, the digital divide is a huge issue, and particularly into rural areas. And there are obviously a lot of policy efforts. Once again, I think we've tried this in the past, not enough progress. So we're going to see, I'm pretty confident we're going to see large investments in improving access to broadband. There's a lot of debate about what is infrastructure, what is not. I don't know anybody who thinks getting broadband to all parts of America is not somehow infrastructure. It really is. It's fundamental to allowing us to do any of those things. As that begins to happen, I have felt very strongly that telemedicine, telehealth is a huge source of improving and promoting equity, because equity comes in all sorts of different forms. But one of the reasons why, for instance, a lot of people, a lot of poorer people, a lot of working class people, a lot of people of color have a harder time kind of accessing care, is because when we think of care and access to care is in this very specific box of go to a primary care doctor or a provider between the hours of 9 and 5, Monday through Friday. For a lot of people, that's really not an option, right? It's just not a choice. I think of like me, I have that choice. I could take a couple hours off in the middle of the day because I have the ability, I have the kind of job where I can do that and it's not a big deal and I can manage it. A lot of people don't have that. And the people who can't do that typically tend to be people with basically less social power. They're more likely to be people of color, more likely to be poor. So to the extent that telemedicine and telehealth really expands those possibilities and allows for more asynchronous stuff, but also allows for more just off cycle, off regular hour stuff, it makes a huge difference in terms of promoting equity. And so there are lots and lots of reasons to do it, but that is certainly among them.
Thank you. Well, I think that concludes all of the questions, unless there are any more last minute questions in the chat, or you have the opportunity quickly to ask one final question. Otherwise, I'll give you the chance to make any last concluding remarks before we wrap up.
Yeah, thank you. And thank you again, Linda, for inviting me and all of you for being here. I guess I'll finish by a point that I started making before. And this gets at a lot of the policy stuff we've been talking about, but it goes beyond that. I said earlier that I get asked a lot, when do we go back to normal? And I say, well, we're never going back to normal if normal was 2019. You know, pandemics have been with us as humans for as long as humans have been around on this planet. And they will be with us for a long time. And pandemics obviously are horrible. And this one has been horrible. A lot of people have died. A lot of people have gotten sick. We're not anywhere near done globally. But for all of the downsides, pandemics also create opportunities for change because they change societies. Crises like pandemics really have this profound effect of opening up possibilities that felt closed years ago. And those windows don't last forever, but they do last a few years. And so one of the things that we need to think about, whether we're thinking about what's the kind of healthcare system we want, how do we change payment models so we promote health and well-being and functional status and the things that actually matter. It is absolutely essential that all of us get involved in this, because if you all don't, somebody else will. And either things will go back to the old status quo, which is a huge missed opportunity, or we'll create something new that's not nearly as good as it could have been. And in this whole pandemic, one of the things I have tried to say to frontline clinicians is you have a huge role to play as voices for public health, as voices for science, as voices for policy. You're not all policymakers, but you understand a set of realities on the front lines that policymakers don't. And making sure that you're communicating that through your specialty societies, to yourself directly, but really engaging in this conversation and making sure we build a better healthcare system, a better public health system. It's really up to us. It's not going to happen naturally. And this is a once in a generation moment. And it's the one silver lining out of a horrible pandemic. And I want to make sure we use it in a way to set ourselves off for a much better, healthier community healthcare system, country in the years to come. So let's make sure we do that.